Welcome to Fresh Perspective, an Obesity Action Coalition series where we explore timely topics impacting individuals living with obesity. I'm Joe Nadglowski, and today we're discussing a timely issue in the news, the phasing out of compounded GLP-1 medications. Many patients who have used these medications are now learning that compounded versions are being phased out. Understandably, this change raises questions about what comes next for those of you who have been utilizing compounded medications for your obesity treatment. Some may feel concerned about access or affordability, while others may be tempted to seek unregulated alternatives or questionable sources online. But there are safe, effective options available. And today we'll talk about what patients can do to navigate this transition. To help us understand what's happening and what steps patients should take, we're joined by Dr. Angela Fitch, a board-certified obesity medicine physician, an OAC board member, and a dedicated advocate for evidence-based care. Dr. Fitch, thanks for being here today.
Thanks for having me, Joe, and thanks for what the OAC is doing to really, educate everyone on this important issue.
Yeah, so let's start with an important question that's on a lot of people's minds right now. What should patients know and do as access to compounded GLP-1 medications begin to change?
Well, they should know that, they have a place to go, right? Like go to your physician, go to your clinician, your nurse practitioner, your physician assistant, whoever you're seeing and really, talk about obesity. We have talked a lot about stigma and bias against the disease of obesity. So many of the primary care doctors or other people might not be as aware or knowledgeable, but seek out, people that can help you to understand the situation and to understand your specific needs and your treatment options, because there are many FDA approved medications that are out there that are affordable that some people might not know even exist, until this GLP-1 sort of era of treatment.
Yeah, thanks for that. And so many patients really turn to these compounded medications because of cost or availability issues. What options exist now for those who are concerned about affordability and access?
Yeah, it's so important, right? I mean, the compounding loophole or the compounding situation was designed to, meet a small need when there's a shortage. And when there's a shortage, but hopefully those patients have coverage for that drug during the shortage, meaning we've never experienced a time where not only do we have a shortage of these medications, but only about 48% of the population have access to coverage for these medications. So we've really been solving a coverage problem, with the compounding solution when really it's meant to only be there for during times of shortage. And so again, we recognize that there's a significant need. And as you know, we've been doing a lot of advocacy over the past 12 years, even to try to really get obesity treatment as a standard benefit on people's insurance. And that way we could help to improve the coverage of these types of treatments. And so today, fortunately, our manufacturers of these medications of GLP-1s, such as Novo Nordisk and Eli Lilly, have created cash programs that are a bit cheaper than what you would find if you had to walk into the pharmacy and pay cash for your medication. So now there are cash programs from both companies that put the drugs at about a $350 to $499 price point, depending on the dose of the medication. And so at least there is that option. We recognize we'd all like it to be much cheaper than $499. But for now, we do have access to those medications, the FDA approved versions of these GLP-1 medications in this manner.
Yeah, and thanks for that. And so I know this happens, although you live in a state with pretty much the best coverage in the country from Massachusetts. But when patients come to you worried about affording their medicines, what kind of practical ways have you helped them overcome cost barriers with these FDA approved branded products?
That's a great question. And, while I am fortunate that most of my practice occurs in the state of Massachusetts, at my clinic, Known Well, we do have clinics across the country and we do service patients. As of April 1st, we'll be able to service patients in 50 states across the country via telemedicine. So again, being able to provide access is super important and I'm super passionate about that. We have FDA approved medications for obesity that we've had, since the 1950s even. So we have phentermine, topiramate, bupropion, naltrexone. those medications are put together in the drugs Qsymia and Contrave. And each of those companies that make those medications actually have access via an online pharmacy as well. Any prescriber, such as myself, can send a prescription to these types of pharmacies hosted by the manufacturers so that they can get access. For the Qsymia and for the Contrave, it's $99 a month. The components of phentermine and topiramate, for example, which are the individual components of that combined medication, they are available for under $30 a month for most patients. And so again, there are these alternatives that we can utilize for some patients. We recognize some patients can't tolerate all different sorts of medications depending on their risk factors and side effects, but at least there's something there for them, to be able to try to access. We also have some creative ways that we are able to get coverage today. And I don't say creative in a bad way, but for GLP-1 medications, for example, there's a new indication now for tirzepatide or Zepbound for sleep apnea. So for some patients, they might not have coverage as it relates to weight management, but they might have coverage if they have another condition such as sleep apnea. Or for our drug semaglutide, which is known as Wegovy for the treatment of obesity, it also is approved for those patients who've had a prior cardiovascular event, such as a stroke, heart attack, or poor circulation in their legs. And so again, we have that indication that we can try to help patients get access for those medications. So more and more today, we are seeing a bit better access for these types of treatments than we have in the past.
Dr. Fitch, I know my own provider, I've happened to use one of these GLP-1 medicines and use a branded FDA-approved medicine, but I've never taken the full dose over these same cost issues. But that was another way that some skilled providers can guide you around either dosing over longer periods of time or adjusting your dose to be able to take these. Do you do that regularly with your patients as well? So.
Yes, that's a good point to make. For some patients, they might take them every 10 days instead of every 7 days. They are indicated to be taken every 7 days, but some patients are able to stretch them out, especially if they don't have a lot of side effects. The downside there is if you're giving yourself a bit of a bolus every 10 days, sometimes that can exacerbate side effects a bit, when you haven't had it for those 3 days, when you were supposed to take it every 7. We try to stick to the FDA labeling as much as we can, but also recognize there are those situations where, we have to try to get FDA approved medications in manners that are more cost effective. We also have patients who, for semaglutide, for example, may decide to buy the drug Ozempic. Even though that drug is approved for diabetes, it does come in a pen that can be dosed differently, a clickable pen that, not a single unit dose pen, but a pen that has multiple doses, included in it. And so we can sometimes prescribe that medication, and that can sometimes be a more cost-effective route for the patient to pay cash for if they're on a smaller dose and make that pen last a bit longer. So there are these types of things that we can do for patients, especially now that the shortage is over and we're not as concerned about maybe patients with diabetes, going without their medication because we don't have access to the Ozempic. The Ozempic and the Wegovy, as you know, same as the Mounjaro and the Zepbound, those are the Ozempic and Wegovy, same exact drug, just two different containers. Same with Mounjaro and Zepbound, same exact drug, just two different packages, two different indications. So again, if we do have some overlap there where some patients may have coverage even for one versus the other, we can check on that and we can try to get creative around, which one might they have access to, for their treatment.
Yeah, thanks for that. And I think, when we think about compounding, I think safety is obviously the utmost concern for most of us. I think you and I having had lots of conversations about that. So if you are a patient who is using a compounded product, are there additional things that you, as my provider, if I was using a compounded product, that you would be evaluating me for and that patients should be aware of, that they should be talking to their provider about if they are using a compounded product?
Yeah, I think they should definitely talk about it, with their clinician, and we don't have much data because we just don't know. And that's what we've said all along is that, the issue isn't that maybe, many patients have found these compounded products to be effective for their treatment. So it looks like there might be something effective in there that is being utilized for treatment. However, we've also heard stories of patients that have ended up with kidney failure and liver failure and other sorts of issues acutely, because there might be other impurities or other things in there. If you haven't had a problem on your compounded agent right now, like if you didn't have an acute problem, then it's probably okay. It probably hasn't done any discrete damage, to any of your organs or anything that we're aware of. But it would be something where we would encourage patients to, again, seek out an FDA-approved alternative that we know is safe and effective, or we know the data on it, at least from a safety perspective. Because what we don't know about the compounded product is if you were to continue to take it ongoing, is that safe in the long term, right? Under long-term exposure conditions. And that's what we're concerned about. And there really isn't any specific testing we can do, or, we might just normally do some testing, like we look at people's kidneys and liver and can do blood testing around that. But there's not going to be any kind of scans or any type of testing that's going to tell us. And that's really been our concern all along with the compounding process, is we just don't know. And if you don't know, maybe you don't want to inject that, inside your body, if we don't know.
So I think we both agree that we probably wouldn't be here today if everyone had access to these medicines under their health insurance. And this really highlights the bigger issue that most people struggle getting access to such medicines. So curious to your thoughts about where we should go next on this fight for access to care.
Well, as you know, Joe, as I've been saying all along, I really think that obesity should be a standard benefit on everyone's insurance, everyone's commercial insurance, everyone's Medicare, Medicaid. The coverage of the state of the disease of obesity, the care for the patient with obesity around, their holistic, comprehensive, longitudinal care across their lifetime. Because as you know, this isn't an acute problem we're just solving momentarily. We have to work on this issue throughout the course of a patient's lifetime. And that's what we want patients to hear, and patients to know that we're here for that. As obesity medicine trained clinicians, seek us out, try to find us. A lot of us offer telemedicine services now, so you don't have to be, located exactly in the same place that there is an in-person clinic to be able to access care. And really, we have to advocate, all of us in the United States of America, whether we are living with the disease of obesity or not. I think we should all stand up and say it's not okay that the American Medical Association in 2013 said that obesity is a disease, and yet it's not a standard benefit on everybody's insurance plan. And it really should be. And then the thought is that would also then drive down the cost, interestingly. The CEO of Eli Lilly, in a public statement made at an event, to the public, said that these drugs could be priced much lower if everybody, had access to treatment. Because again, if you're trying to figure out what your market looks like, it's hard to figure out if every day it's changing. If every day there might be less people covered or more people covered, you can't really predict for that as you're building out your supply and your company and your pricing strategy. So we really need this to be, a standard benefit for everybody. And then, we could definitely, I think, see some change.
Couldn't agree with you more. I think that's what OAC does. We fight every day to try to improve access to all obesity treatments, including these medicines. And we appreciate all of our members who have joined us in that fight. So Dr. Fitch, this has been such an important and reassuring conversation. We know this change feels sudden or even overwhelming to some, and that's completely valid, but it also opens the door to safer, more consistent care. And the good news is no one has to figure it out alone. There are resources, support, and real and safe solutions for all of us. One of the most powerful ways to improve access to care is through advocacy, and that's where the OAC comes in. The OAC is actively working to remove barriers to treatment, expand insurance coverage, educate policymakers, and reduce weight bias. If you want to stay informed and take action on these issues, sign up for OAC's Advocacy Network newsletter. You'll receive timely updates on legislation, opportunities to contact your elected officials, participating in advocacy campaigns, and making your voice heard on the local and national level. Sign up today using the link on the screen. Dr. Fitch, thanks for your insights, and thank you to everyone for watching today. We'll see you next time.